background. Oh, very quick.
Oh yeah, yeah, it can be quick. Do you do SPECT or PET?
Pet, they don't. I only seen one spect part, but
Okay.
they doing pet part.
Okay, that's good because cardiac PET is going to explode in the next couple of years. There's going to be a lot of jobs in cardiac PET, so you having exposure to that is really good. A lot of students and technologists don't get the exposure to cardiac PET, but we're going to spend most of the time talking about SPECT because you're going to see more SPECT on your exam than PET. All right, so when we look at our slices, um, we get 3 different slices. Okay, what are the names of the slices? What's the top one?
Short access,
Okay, and what's this one? Second one?
horizontal,
Horizontal long and
vertical.
yes, very good. Okay, and when we label these walls, what is this wall?
This is the septum.
How about this one?
It's the anterior.
Yes, this one?
This is the apex. A ladder,
And then this one?
inferior.
Perfect. All right, how about this one?
This is septum also.
This
I
one?
used it second ladder.
Perfect. This one?
This is the apex, anterior,
Anterior. And then this one?
inferior,
Inferior. And then this one right here?
apex.
Apex. Very good. And this is also apex. Okay, excellent. All right, so when we image MPI, I'm just making sure, did I start recording? Yes, I'm recording. All right, when we image, we're only imaging the left ventricle. How come we only image the left ventricle and not the right ventricle?
This is working hard the most.
Yes, yeah. What would cause us to see the right ventricle?
I'm sorry.
What would cause us to see the right ventricle? So you can kind of see the right ventricle here. How come? Pulmonary hypertension. Pulmonary hypertension. And so if there's restriction of the blood going through the lungs, it's going to cause the right side to work harder. It causes the muscle to build. And so that's why we would see, occasionally we can see that. All right, the slices themselves. So the short axis slice is going to be sliced in this way, and the slice is from the apex to up to the base. Horizontal long would be like this, but since we want to mirror all the other imaging modalities, we flip it upside down like this. Okay, otherwise, anatomically, this is what it would look like. But this is what we're going to see. So the slices here are anterior to inferior. And then these slices, where are these sliced from?
This would be in septum to lateral.
Septum to lateral, yeah. And the way that you can remember that, okay, because you already told me this is septal and this is lateral. So the 2 that are missing here are anterior and inferior. So that means that the slices are anterior to inferior. And the 2 slices we see here are anterior and inferior. The 2 that are missing is septal and lateral. So the slices are septal to lateral. All right, the coronary arteries. We need to know which coronary arteries supply which walls. So the right coronary artery is the inferior wall. The left coronary artery breaks into the circumflex and the left anterior descending. The circumflex, think of it as circling around to the lateral side of the heart. The anterior descending is anterior, literally has the word anterior in its name, and the septum. Okay, so what happens when somebody has a heart attack? Well, this is a normal artery. This is an artery that's blocked. And so what usually happens is when the patient is just resting, there's enough blood flowing through that you're just fine. But when there's a blockage and you are exercising, now all of a sudden you have an increased demand on your heart and you need more blood flow. The normal arteries will dilate, the abnormal ones will not. And we take advantage of this on our imaging because on our imaging, what we see is it's always a comparison. Like what counts are here compared to what counts are here. In everything that we do, that's what we're comparing. And so when we compare our stress to our rest, what we are looking for is what area of the heart has more counts than the other area of the heart. And so if there's a blocked artery at stress, it's going to divert blood to the unblocked artery. And so you're going to have less counts in the blocked area. And that's why you're going to see a defect in that area. Now, we're going to do rest and we're going to do stress. And this is if you're going to do cardiac PET or cardiac SPECT. And for each of these, we're going to inject. With PET, you're not going to wait. Inject, wait, and image. With stress, you're going to inject, wait, and image. Now, why in SPECT do we have to wait after the injection before we image?
For the liver and the stomach to pass.
Very good. Yes, for the liver and the bowel and the gallbladder, absolutely. All right, for the stress portion, there's a lot of things we can do. We can do exercise or pharmacologic. The two ways of doing exercise is either a treadmill or a bike. And here in the US, we use the treadmill. When I went over to Europe, they were using a lot of bikes. Pharmacologic stress, we have a lot of options. So we have 3 vasodilators, and then we have 1 that is more like exercise. All right, our goal with exercise is increasing the heart rate. Now, when we exercise, we're also increasing blood flow to the heart. When we use a vasodilator, we're not increasing blood flow to the heart. What we're doing is, with the blocked arteries, we're moving the blood flow from one area of the heart to the other, but we're not actually increasing the total amount of blood to the heart. And that's important because with exercise, if you have increased blood flow to the heart, you have less blood flow to the liver. And so you can image sooner, and your images are going to be better. So ultimately, exercise is always the better test to have, but most of our patients can't exercise. Now, if they exercise, how high do we want to get their heart rate?
Use the Bruce protocol.
The Bruce protocol is what we're going to use to get their heart rate up, but how high, how do we know when their heart rate's high enough?
So 220 minus the age times 8.85.
Yes, very good. And once they reach that target heart rate, we're going to inject the radiotracer, and then we're going to have them walk for another minute or so, because we want that minute of time while the tracer is extracting from the blood to go to that area of the heart and stick there. And that's what it does. It sticks there. So we can image later. And when we image later, we're going to see what the heart looks like at the moment of injection. So issues we can have, maybe the heart doesn't increase. What kind of medication would prevent the heart rate from going up? Beta blockers. Beta blockers. Those are the drugs that end in LOL. So atenolol, propranolol, esmolol, those keep the heart rate low. So patients on beta blockers cannot have a treadmill test. Heart rates that are slow to decrease after exercise. So to know if you're healthy, your heart rate goes up slowly and it comes down fast. So if the heart rate is slow to decrease, that's common in patients that have heart disease. Chest pain, shortness of breath, that's certainly a problem. ST segments, looking for ST depression, and then any kind of dysrhythmias. All those things can happen on the treadmill. This is the Bruce protocol that you talked about. This is the stage. It changes every 3 minutes, and every 3 minutes, the speed and the grade go up. I don't think they're going to ask you for these actual numbers, but just know every 3 minutes, it increases in speed and grade. There's also a modified protocol for patients who cannot do the Bruce protocol, and that starts flat, 0 grade. All right, pharmacologic stress. We're going to spend some time on this one. So there's 4 of them. The first one is dobutamine. Dobutamine, think like exercise, because we're doing the same thing. We're trying to get to 85% of the maximum, and we're doing it by every 3 minutes. We're going to increase the amount of drug that we give to the patient. The amount of drug we give is measured in micrograms per kilogram per minute. And we're going to go through an example. So get your calculator ready. Now, once we get to 85% max, then we inject the radiopharmaceutical. We keep the infusion going for another minute or so, and then we stop the infusion. So just like exercise. All right. You can start at 5 micrograms, but this one's optional. Most places will start at 10. So if I have a 150-pound patient, first thing I have to do is convert to kilograms. So how many kilograms is that?
A 2.2
Mhm.
would be 68.
Okay, so 68 kilograms. If my question was, what is the dose rate for um, the first part of a dobutamine, how would I figure that out? Dose rate.
Oh, times 10.
Exactly. So 68 kilograms, and it's going to be 10 micrograms per kilogram, gives me 680 micrograms per minute. That's the dose rate. So dose rate is always how much drug per unit time per minute. If the question was, what is the total amount of drug I give for the first phase, then how would I figure that out? So I'm given 680 micrograms per minute. How long am I giving this drug?
For 6 minutes.
Not 6 minutes. Each phase is 3 minutes.
So times 30.
Times it by 3, yes. And so that actually comes out to 2,040 micrograms, which is 2 milligrams. So your answer would be 2 milligrams. Okay. And so you could do it for all 4 phases if you wanted to. But basically, look at the question. Are they asking me for the dose rate or the total dose? Dose rate is going to be per minute. All right. What is atropine?
With the heart, if it's not enough, then they have to give this.
Yeah, so this is actually a medication that's on the crash cart. When patients come into the emergency room, their heart rate's really low, they give them atropine. Atropine causes the heart rate to go up. So if you're doing a dobutamine and the heart rate is just like, gosh, I need another 10 beats per minute, and you're all the way to the end of the protocol, you're at 40 micrograms per kilogram per minute, and it doesn't achieve the 85%, you just give them a dose of this. And this usually, it doesn't come in a vial, it's usually in a unit dose. It's a pre-filled syringe. And you just give them a shot of that. It usually gives you the last 5 to 10 beats that you need. All right, the 3 vasodilators, dipridamol is a total dose. Adenosine is a dose rate. Both of these are weight-based. Regadenoson is the same dose for all, and there's no dose rate. You're just going to give them the dose. So let's talk about how these drugs work. So this is in the blood, this is in the cell, and this is the cell membrane. These are different receptors that are going to assist these things to cross the cell membrane. So if you look at adenosine, one thing you notice is there's adenosine all throughout the body. Okay, you have adenosine in your body right now, and so do I. Your body increases its amount of adenosine with the fight or flight response. So if you get scared, if you have to do public speaking, if something like your body produces adenosine. So adenosine goes to 3 receptors, A1, A2A, and A3. The A1 receptor is responsible for AV block. The A3 receptor is responsible for bronchospasms, 2 things we don't want. The A2A receptor is vasodilation. That's what we want. Regadenoson also goes to the A2A receptor, but does not go to these other 2 receptors, which means that regadenoson has fewer side effects. If a patient has COPD, they can get regadenoson, but they cannot get adenosine. If a patient has first-degree AV block, they can get regadenoson, but they cannot get adenosine. What is AV block?
Atrial
Okay. Yeah. Okay, so you have the atria at the top and the ventricles at the bottom. And what's happening with the electrical signal of the heart, the electrical signal starts at the atrium and then it moves down the ventricle, and that's one complete heartbeat. If there's an AV block, there's a block in the electrical signal. It's not a block in the arteries, it's a block in the electrical signal. And so there's first degree, second degree, and third degree AV block. This receptor here, adenosine, can cause you to go from first degree AV block to second degree AV block, or from second degree to third degree. That's why we don't give you adenosine. but regadenoson doesn't go to that receptor, so it doesn't cause AV block. All right. Two other things that go to the A2A receptor: C, caffeine. That's why our patients cannot have caffeine. All right. How long do your patients have to be off caffeine before they come in?
6 hours.
6 hours. Okay. Usually it's 24 to 48 hours. 6 hours is kind of short because caffeine sticks around for a while. So on your board exam, it's going to be 24 to 48 hours. All right. Methylxanthines. This is a class of drugs like aminophylline and theophylline, and that also goes to the A2A receptors. So that medication we can give as a reversal drug. If the patient's having side effects, we can give them aminophylline because it's going to go to that same receptor and stop it from working. All right, now, where's dipyridamol? It's a good question, right? Do you see dipyridamol anywhere?
Yeah,
right here. Yep. So what dipyridamol is doing, it is blocking this adenosine from breaking down. Okay. And so basically it doesn't allow the adenosine goes back and forth. See that goes back and forth. But the dipyridamol basically says, no, I'm going to keep all the adenosine in the cell. And so, like I said, your body has adenosine in it right now. Dipyridamol allows your normal adenosine to build up. So dipyridamol is the same thing as an adenosine stress test, except it's indirect. It's indirect. Okay, so let's talk about how we give these. Adenosine, this is a dose rate. And the reason it's a dose rate is because the biological half-life is really short. That means that it's going to be gone very quickly. So we have to give a continuous infusion, and the radiopharmaceutical is given in the middle of the infusion. Unless it says otherwise, it's going to be a 6-minute protocol. Okay, 6-minute protocol. All right, your patient weighs 150 pounds. What is that in kilograms?
68.
68 kilograms, very good. If the dose rate is 140 micrograms per kilogram per minute, what is my dose rate?
We got time 140. So it would be 9545.
Very good. All right. So that's my dose rate. Now, what's my total dose?
And we're going to divide it by 1,000 for the.
Okay, that's your milligrams. So that's the dose rate. Now, how do I get the total dose?
Times 140.
I'm going to times by 6. I'm times by 6. So I'm going to get my dose rate by taking my kilograms and times them by 140. That gives me my dose rate. That's how much they're getting every minute. And they're going to give it to them for 6 minutes. So we times by 6 to get the total dose.
So 68 times 140 times 6.
Exactly. Yeah.
Okay.
You got it. All right. Dipyridamol. This is a total dose. So you see it doesn't say milligrams per kilogram per minute. It just says 0.57 milligrams per kilogram. We're going to give it over 4 minutes, but this is the total dose. So we're going to give it over about 4 minutes. If the patient has side effects, we can slow it down. At the end of the infusion, we're going to wait 3 to 5 minutes and then inject the radiopharmaceutical because we're waiting for the body's own natural adenosine to build up. That's why we're waiting. All right, 150-pound patient. What is it in kilograms?
68.
68. Yeah, I did that on purpose, the same pound patient, so we didn't have to calculate that each time. All right, how do I figure out the total dose?
Times 0.56 would be 38.
38, perfect. Yes, 38. All right, and then regadenoson. Is this what you're using in your stress tests?
Yes.
Okay, all right. So regadenoson, super easy. Everyone gets the same dose. You inject it. After you inject it, you flush. After you flush, you inject the radiopharmaceutical. Super easy. Is that about the same way you're doing it?
Yes, so we have a rubidium generator. It's a GE PET scanner. So the doctor, they will inject on the other end and then inject and then flush and then the rubidium and then we'll go out.
Perfect. Yep. Very good. What are your doses for rubidium?
That I don't know.
Is it 30 and 30?
I think so.
Okay, because it used to be 50 and 50, but I think that was for a 2D PET scanner. With a 3D PET scanner, you don't have the SEPTA. So I think it's been lowered to 30 and 30, but I have to look that up.
Okay, I'm gonna check my protocol too.
Yeah, check it and send me an email because I'm always curious about that. I try to talk to people who are actually doing the test to make sure that my information stays relevant. All right, what is aminophylline?
It's for to reverse the reaction of
Yes,
symptoms.
yes, because it goes to a certain receptor. What receptor does it go to?
A2A receptor.
Yes, very good. A2A. You are getting this. All right, so liver and bowel interference. This is why we wait. Now, rubidium is different. Rubidium is like thallium. Thallium has a very high extraction fraction. What does extraction fraction mean?
Wash that out.
It's basically the amount that's extracted from the blood into the myocardium every time it goes through. So every time it goes through, a certain percentage is going to be pulled out of the blood and it's going to go to the heart. Rubidium and thallium are both potassium analogs, and so it has a high extraction fraction, which means your images don't look like this, do they? No, because sestimibie and tetraphosphamide don't have a high extraction fraction, and so we see this. Now, the first thing that we're going to do when we process a SPECT MPI is we're going to draw our limits. All right. Now, everything above and below it, we get rid of. In this image here, you don't have a whole lot of liver that's going to interfere, but in this image, you've got a lot of interference with the liver. And so this is why we wait after we inject before we image, because we have to let that clear out. What are some of the things that we can do to cause this to clear out other than time? Sometimes we give ice water. That's going to help any bowel clear out. Sometimes we give crackers and milk. That can help it clear out. I worked for a cardiologist years ago, and his office was right across the street from a McDonald's. And our patients would come in, we'd give them a resting injection, and we'd send them to McDonald's. And we're like, okay, go get a sausage biscuit. And they're like, what? You're a cardiologist. Like, seriously, it's going to make your images look great. They'd come back, every bit of this was cleared out. It was beautiful. That's just kind of how it goes. Okay, so a lot of different protocols. All right. So we need to go through these protocols. So there's a 2-day protocol. And if the benefit of doing a 2-day protocol is you can give the patient 2 high doses. If you do it in 1 day, 1 dose has to be high and 1 dose has to be low. So this is really if you have larger patients and you don't want to give them a low dose, 2-day protocol. 1-day protocol, you always have to do the low dose first, followed by the high dose. You can either do the rest first or the stress first. Why would we do the rest first? What would be the advantage?
Because stress is more important.
Yes, very good. Stress is more important, so we want that to be the high dose. Why would we do stress first?
If the patient not able to tolerate, maybe they can't, they're not doing well.
Well, if we do stress first and the stress is normal, we don't have to do the rest. And that's also the benefit of a 2-day. You do stress first. If the patient is normal, they don't have to come back for the rest. All right, thallium, you must do the stress first, okay? Because thallium is not stress rest, it's stress redistribution. So we're not giving a second injection, we're just waiting for it to redistribute in the heart. And dual isotope, we do thallium for rest. And when we do that, we inject, put the patient right on the camera because we don't have that bowel interference. And then we wait and we use TAC for stress. All right, I'm going to skip through these because this is just everything that I already said. Okay, the image acquisition itself, dual-headed camera. I don't think anybody's using a single-headed camera anymore. The camera heads are going to be 90 degrees apart, and we're going to go 180 degrees around the patient, not 360. How come we don't go all the way around the patient?
We want to take the RAO and the LAO.
Okay, so we're going from the RAO around to the LPO. We don't do the other 180 degrees because of attenuation. So while we'll get more information, the information we're going to get is bad information. And so that's going to degrade the image and it doesn't help us. So that's why we only go halfway around. Anywhere between a 60 and 64 projections. These are the actual images, not the stops. If you have a dual-headed camera, you get 2 projections per stop. Begin at 45-degree RAO, anywhere between 8 and 25 seconds per projection. It just depends on the camera. It depends on the electronics in your camera. And then, of course, you have, the C cams now and all kinds of different instruments that this is variable. Back when I was in school, this was like set in stone. Now it's anything goes. All right. Explain to me normal versus ischemia versus infarct. And this is stress over rest.
So ischemia is they show up on the stress,
Mm-hmm.
and then rest is normal.
Mm-hmm.
Then infarct is both the normal.
Yes, matching defects. So this is mismatched, this is matching, this is both normal. Excellent. So here's an example, no evidence of stress-induced ischemia. We've got the short axis, the vertical long, the horizontal long. Those are beautiful heart images. This is an example of stress-induced ischemia. Which wall is that?
This is the lateral.
Uh-huh. Yeah, lateral wall. And so the lateral wall has the circumflex that supplies blood to it. And so that's where the blocked artery is, and it fills in on rest. All right, this is breast attenuation. What wall will breast attenuation affect?
That's the anterior.
Yeah, that makes sense because our breasts are anterior on our body. Diaphragmatic attenuation, what wall will affect diaphragmatic attenuation?
Inferior.
Inferior, yeah, because the diaphragm is inferior to our heart. So some of these things is just thinking about anatomically where things are. Now, this is that defect I showed you in the beginning, where you have this artifact where you have all of this activity in the resting image that's interfering. And so look at what wall it affects. It creates a defect in the inferior wall. And that's why we have to wait. The only way to fix that is to respect. You got to respect your patient. Yeah.
How long would the wait will be?
Minimum 30 minutes, but some protocols are 60 minutes. So 30 to 60 minutes. And the same thing with stress. If you're giving a vasodilator, you want to wait about 45 minutes, anywhere between, 30 is probably not enough. 45 minutes to an hour for vasodilator. If it's exercise, because you have increased blood flow to the heart, you can get the patient on there earlier. Or if it's thallium, you have to put the patient on quickly because it starts redistributing. Okay. Attenuation correction. So this is an uncorrected stress image. And this one has CT used for attenuation correction. When we correct for attenuation, do we take away counts or add counts?
Corrected is added count.
We add counts. Yes, very good. We're adding counts back in because attenuation is literally the removal of counts. And so to fix that, we have to add those counts back in. And the CT, what it does is it takes a very fast X-ray and identifies every pixel, and it identifies an attenuation correction factor for each pixel and compares them to each other, and then adds those counts back wherever there's attenuation. All right, what types of imaging is this? What do we call these images?
This is the infection factor.
Gated images. Yeah, those are gated. Okay. So when I say type of image, that means is it static or planar, whole body, dynamic, gated, SPECT, PET. Those are types. So these would be the gated images. Now, what we're seeing here is this is the R to R interval, okay? And this is the ventricle that is contracting. This distance between the R and R to R interval is a unit of time. And this unit of time is going to be broken into gates, okay? And these gates are going to hold the counts. So whenever the R triggers, the counts go into the first gate until this unit of time is over. And then the counts go into the second gate until this unit of time is over. And then the third one, and so on, until another R triggers. And when another R triggers, we go back to the beginning. And as long as the heart rate stays consistent, we're going to get an even number of counts in all of these gates because it's going to make it all the way to the end. Now, if a patient has an irregular heartbeat, that R might trigger early or it might trigger late. If it triggers early, I'm not going to have any counts in my last few gates. If it triggers late, I'm going to have a whole lot of extra counts in my last gate because it's sitting out in this last gate. It's waiting for the R to trigger again. So as long as it's an even heartbeat, you're going to have the same number of counts in each gate. Now, this happens very fast because this entire thing is one heartbeat. So every heartbeat, it does this. And then it adds all the counts back together to form these images. Okay, but it separates the counts to form these images into those gates. So you're seeing those 8 or 16 gates on a loop. Okay, you're seeing the exact, it's the average of all the heartbeats on a loop. So if you image your patient for 10 minutes, this is the average of heartbeats for 10 minutes. One heartbeat you're seeing over and over again. Now, we're going to use that to calculate the ejection fraction. All right, so we're going to draw regions of interest. This is end diastolic. ED, think dilate, so big. ES, systolic. And we're going to draw our regions of interest. But instead of asking how many counts are in our circle, because usually when we draw a region of interest, it's like how many counts are there? There aren't any counts there. We're going to ask how many pixels are there? How many pixels? What is the size of that region you drew? And then the pixels, the number of pixels are going to be converted to milliliters. So your end diastolic volume is going to be in milliliters. Your end systolic volume is in milliliters. And then we can take these images, these 8 frames, and we can graph it. So this is the first R, and this is all the different points in that gated image, all the different points, the volume, the size of that ROI. So it's going to get smaller and then it's going to get bigger again. We take the biggest one and the smallest one and we calculate the ejection fraction. So what is the equation for ejection fraction?
It's the EDV minus ESV divided by EDV.
Yes, very good, very good. Okay. All right, the other thing we can do is something called 17 segment scoring. This is a way to quantify the uptake in each area of the heart. And so what we're going to do is we're going to take a short axis, 3 short axis slices, one at the apex, one at the middle, and one at the base. And we're going to stack them on top of each other. It's kind of like that little donut play toy where you have the thing where you put the plastic donuts on top and you have to put them in the right order. We're going to do that, except we're going to use 3 short axis slices. And then on the top, right here in the middle, can't see that, right here in the middle, we're going to use the apex from the horizontal long and the vertical long. And what we're going to do, what you see here is this is the short axis from the base. This is the short axis in the middle. This is the short axis at the apex. And this is the apex from the vertical long and horizontal long axes. And we're going to break those into 17 segments. So here are the 17 segments. You've got 4 in this apex, and then you have these and these and these. So that's not important. Just know it's 17 different segments, and we're going to ask the computer how many counts are in each of those segments. So we're looking for an area where we have absent counts. or less counts than normal. So the higher the score, the worse. If you get scores of 0, that's normal. Now we're going to do it for stress, and we're going to call that the sum stress score. We're going to do it for rest and call it the summed rest score, because we're going to add them all up. And then we're going to subtract the two, and we're going to call that the summed difference score, because we want to know if there's a difference between stress and rest. And what that tells us is it reversible? That says reversibility. I know it's really small. Okay, so let's look at a couple of these. Here we have a summed stress score of 27. Why is it 27? Because we've got some blue in here, and we've got some green in here. And so these segments, it's going to be scored between 0 and 4. We've got a high score. Our resting score is 1. So that tells us our rest is pretty much normal. When we subtract these two, we get 26. A high sum difference score means high reversibility. All right, this one, sum stress score is 21. You can see it right there. Summed rest score, also 21. When we subtract it, we get a sum difference score of 0. There's no reversibility here because it is a fixed defect. They're the same. All right, now we can also take that same thing. Sometimes we call it a polar plot. Sometimes it's called a bullseye. And we can, it's the same slices, septal, anterior, lateral, and inferior, same labels. And now we can look at which arteries supply each one. All right, how do you feel about EKGs?
This is my worst.
Okay, well, I'm glad that we're talking about this now. Okay, so what does the P wave represent?
The AV notes.
The atria contraction. All right, what is the QRS?
The ventricular depolarization.
Or in simple terms, it's when the ventricles are pumping. Okay, so P is when the atria pumps, QRS is when the ventricles pump. The T wave is the repolarization, so that's the ventricles getting ready to pump again. Okay, now the atria do that too, but we can't see it because it's lost in the QRS. All right, so the QRS, we can see it here. Atria, we can't see it because it's lost. All right, so a couple things. Normal heartbeat is between 60 and 100 beats per minute. Fast heartbeat is over 100. What do we call that?
Tachy.
Tachy. All right, slow beat is less than 60. What do we call that?
Bradycardia.
Bradycardia. Yeah, see, this isn't your weakness. You're doing great. All right, this is called the 6-second strip. So over 6 seconds, this is what we get. We can figure out the heartbeat by counting these. 1, 2, 3, 4, 5, 6, 7. 7 times 10, heart rate is 70 beats per minute. Okay, so that's called the 6-second strip. All right, we're not going to go over all of these. We're going to go over the ones that I think you might see on your board exam. So this is normal sinus rhythm. We're going to look and see if the R to R intervals are the same. We're going to look to see that there's a P wave before each QRS. We're going to look at the interval between the T and the next P is the same. Okay, so we're just looking for consistency, that the distance between all of these are the same. Sinus bradycardia, what's the heart rate?
60 and the 60.
What's the heart rate in this one? This is a 6-second strip. Count them and times it by 10.
4. 40.
40 beats per minute. Yep, that's how we know it's sinus bradycardia, because 40 beats per minute. All right. What's the heart rate on this one?
120.
120. Yes, 120 beats per minute. All right. So all three of these, I said sinus, normal sinus rhythm, sinus bradycardia, and sinus tachycardia. What does sinus mean?
Sinus notes in the heart.
So this is the sinoatrial node. That's the pacemaker of the heart. Okay, so that is right above the atria. That's where the heartbeat starts. And if the heartbeat starts in the SA node, the sinoatrial node, then we call it sinus rhythm. Okay, so these are sinus rhythm because that's where the heartbeat is originating from. There are other pacemakers. There's the AV node, which is in between the atria and the ventricles. So if the SA node doesn't trigger, the AV node will kick in. And then there's also the bundle of His that will contribute as well if the AV node doesn't. You have a lot of backup mechanisms in the heart. So sinus rhythm means it starts in the sinus, the sinoatrial node. Okay, this one is a pattern that I think is hard to see, okay? We can see that something's going on here, right? We just don't know what. So it's always good to walk this out. And what I mean is I see a P, I see a QRS, I see a T, I see a unit of time, I see a P, a QRS, a T, a unit of time, a P, a QRS, a T, there's no unit of time. So that means that this beat came early. That's a P wave. A P wave is an atrial contraction. If it came early, it's premature. So it's a premature atrial contraction known as a PAC. That's what a PAC looks like. Okay. Now, premature ventricular contractions are easy to see because they're just big, ugly beats. Okay. Those are premature ventricular contractions. There's a lot of different types of premature ventricular contractions. First one is bigeminy, which means normal beat, PVC, normal beat, PVC. Every other beat is PVC. Trigeminy, normal, normal, PVC, normal, normal, PVC. Every third beat is a PVC. If you have two PVCs in a row, we call that a couplet. Three PVCs in a row is a triplet. Four or more is called a run. So after a while, we quit counting them. We just call it a run. All right, the other couple ones I want to talk about is atrial fibrillation. So normally the beat starts in the SA node, it goes nice through the atria pump, then the signal goes through the ventricles and the ventricles pump. But if the signal gets caught up in the atria, and so instead of going through, it just kind of circles around, the atria doesn't know what to do. So it just starts fibrillating instead of a nice solid beat. And when it does that, this is what it looks like. Your QRS become irregular because your QRS don't know whether to pump or not because it's not getting a good signal from the atria. And you can't make out the P waves because they're just fibrillating. So this is atrial fibrillation, all right? So our beats are not normally spaced. You just have a lot of ugly stuff in between. And then atrial flutter is like a regularity to fibrillation. So it's fibrillating, but it's doing it in a very regular way. By the way, atrial fibrillation is what is picked up on your Apple Watches. It's saving a lot of lives actually, because it can pick up atrial fibrillation and tell you. Because if you catch atrial fibrillation early, you can reverse it. But a lot of people don't know they have atrial fibrillation, so it's actually saving a lot of lives. And do you know how they reverse atrial fibrillation? They basically, like if your computer breaks, you turn it off and turn it back on. We're going to do the same thing with the heart. We're going to turn it off and we're going to turn it back on. And what we're going to give is adenosine.
Oh.
Same thing we use to stress the heart, except we're going to bolus it, causes the heart to stop. And then when it starts again, the fibrillation is gone.
Oh.
It's either that or shocking them, and that's not very pleasant. All right, last one we're going to talk about is ST segment, okay? And this is an oversimplification, but I think this is all we need. So the ST segment, of course, this is the QRS, and this is the T. So the ST segment is the segment between the S and the T, this right here, okay? And if we draw a baseline, okay? So if we draw a baseline, that ST segment should be on the baseline. Now here, we draw this line, you see the ST segment is elevated, and here you see the ST segment is depressed. Elevation means infarct, depression means ischemia. This is what you're looking for when the patient's on the treadmill. And if you see it, Then you get the patient off the treadmill, you send them directly to the cath lab, and you don't take their pictures. You're done. All right, we're going to spend some time talking about MUGAs now. So have you ever done a MUGA?
Never seen one.
We don't do them much anymore because ultrasound echo is kind of taking it over. But this one has a lot of different names. So MUGA is the most common name, but could be called gated equilibrium, gated cardiac blood pool. This is the second most common name, that one. I think these are the two that you'll see on your board exam. So we're going to label the blood. We're going to use an ultratag kit, and we're going to label the blood, about 20 millicuries, and we're going to label it with technetium, and then we're going to take 3 gated planar images. So this is what it looks like. This is the left anterior oblique, anterior, and lateral. This is the most important view, and we call it the best septal view. The reason we call it the best septal view is because you can see the septum. This is the septum in between. That's in between the right and the left ventricles. And that allows us to draw a nice region of interest. And we're going to get that end diastolic volume and systolic volume, and we're going to calculate an ejection fraction. When we do a MUGA, we're looking for 2 things. We're looking to see if the walls are equally moving, and we're looking for ejection fraction. We used to do these a lot for chemotherapy patients because chemotherapy is cardiotoxic. We're measuring to see if we were doing more harm to their heart than was allowable to determine if they could continue on their chemotherapy. All right, 3 blood labeling methods: in vitro, in vivo, and modified. What's the difference between in vitro and in vivo?
One is inside the blood, inside the body. One is outside the body.
Yes, so in vivo is inside the body, in vitro is outside of the body. So just an overall comparison, in vivo, we're not taking out any of the blood, so it's safe, it's easy, it's very low cost, and we're going to give cold PYP, and that doesn't mean it's in the refrigerator. That just means that it's not tagged to technetium. Cold PYP, you give them the PYP. PYP goes into the red blood cells, diffuses into them, and then when the technetium comes in, the PYP in the red blood cells reduces the technetium, causing the technetium to bind to the hemoglobin. In vitro, this is the most common way because it has the best efficiency. It has the best tagging efficiency. We're going to take the patient out, we're going to reduce it, we're going to add the technetium, then we're going to inject it back into the patient. This one's not really used. Basically, you're going to take it out and you're going to use PYP to label it, and then you're going to put it back in. It's kind of like the cheap way of doing in vitro because you don't want to pay for an ultratag kit, which are expensive. These are the kits, they're expensive. I've just given you the instructions on how you use these so you can read through them. The important things here is that the reaction vial itself, that's where the stannous ion is. That's the reducing agent. Okay, so that's like the first thing that you're going to do is you're going to add the blood to the stannous ion. The stannous ion, just like the cold PYP, will diffuse into the red blood cell. And then you're going to add the 2 syringes, okay? And these syringes basically get the cells ready for the technetium to come in. It stops anything that has not been reduced, or it blocks the stannous ion that didn't go into the red blood cell. That's what it does. And so when you add the technetium, the only stannous ion, the only reducing agent you have available is what's in the red blood cell, because the reducing agent is what's going to cause the tech to bind to the hemoglobin. Okay, skip through that. All right, I want to spend a little bit of time talking about amyloidosis versus sarcoidosis, because this is one of those newer concepts that just really gets confusing. So amyloid is a protein deposition. Sarcoid is inflammation. Amyloid, we're going to image with hot PYP. This means the tech and the PYP are tagged before we put it into the patient. Inflammation, we image with FDG. So what is amyloidosis? Amyloidosis is basically your body needs these proteins, okay? And your body, when it builds proteins, they fold. And if they fold nice and neatly, that's great because then your body can. But if you fold the proteins like my husband folds towels, then it's a problem. And when I look in my closet, I just get really nervous because my towels are not folded right. That's amyloidosis. And so the heart stops working because those proteins, they form these fibrils and it interferes. That's amyloidosis. That's TEC-PYP. Sarcoidosis is different. Sarcoidosis is an inflammatory response, but it's an inflammatory response that is unnecessary. That's when all the fire trucks come in. You remember the analogy I gave? All the fire trucks come in and they're like, where's the fire? And there's no fire. So instead of leaving, they hang out. They hang out and form these, they're macrophages. They form these granulomas, and these granulomas interfere with the heart being able to function. So amyloidosis is protein buildup. That's TEC-PYP. Sarcoidosis is an inflammatory response. That's FDG. All right, so now we know the difference. Let's go through each one of them individually. Amyloidosis first. There's two types of amyloidosis. There's what we call light chain and ATTR. We're not going to talk about light chain because we cannot image light chain with PYP, only the ATTR. And the transthyretin, think thyroid, this actually comes from the thyroid itself. So light chain, we can't image it. Thyretin, that comes from thyroid hormones. It's a protein that actually carries thyroid hormones. All right, there's two types. Wild type comes from aging. Genetic is hereditary. So it affects the heart. It's restrictive of the heart. And we can image with TEC-PYP because those fibrils, calcium binds to fibrils. And so TEC-PYP, we know, goes to calcium because it used to be a bone imaging agent. We have strong uptake in ATTR, no uptake in long chain. Super easy, no fasting, always encourage hydration with all of our studies. Doses 10 to 20 millicuries of PYP, wait an hour and image. What are you going to image? Planar or SPECT, just kind of, you're looking for cardiac uptake. So we're going to compare the cardiac uptake to the ribs, okay? So if there's no cardiac uptake at all, it's a score of 0. If it's less than the ribs, it's 1. 2 and 3 is going to be positive. That means it's either equal to the ribs or it's greater than the ribs. Here's what it looks like. This one's super easy to see. That's highly positive. We can also quantify it. And when we quantify it, we're going to draw a region of interest over the heart and a region of interest over the other side, the ribs. A ratio over 1.5 is positive. So here, the heart is 15. The other side is 15. Ratio is 1. That's normal. Here, the heart is 26. And you can see there's more activity there. Here, it's 13. Ratio is 2. That's positive because greater than 1.5 is positive. Here, the ratio is 33 to 17. So that's going to be positive. 17 to 17, that's a ratio of 1. That's normal. And if you're able to actually make slices and SPECT these, you don't need to quantify anything. That's positive. Super positive. All right, sarcoid. So sarcoid is all about inflammation. And so we know that the heart automatically takes up FDG. And the heart automatically takes up FDG because the heart uses FDG for energy, uses it for glucose. So what we have to do is we have to tell the heart, don't take up FDG because we're trying to see if there's inflammation. So we kind of have to trick, we kind of have to take advantage of the heart being passive aggressive, if you will. So what we're going to do is we're going to take away all of the sugar from the heart. So for 24 hours, no sugar at all. Okay. All you get is fat. And instead of telling the patient what they can't eat, you should tell them what they can eat. Otherwise, they're going to figure out how to eat something that's wrong. And then at the end of the 24 hours, then we're going to say, don't eat anything for 12 to 18 hours. Now, what does the heart do? The heart's very passive aggressive. It loves glucose. We can see that we want this for viability, but not for sarcoid. And so then we take away, and the heart's like, fine, I am going to burn free fatty acids because I'm going to stay alive. And so then when we inject the FDG, it's not going to take it up as glucose. It's only going to take it up if it's inflammation. All right, so once they've been prepped properly, then we're going to inject them with 10 to 15 millicuries FDG, wait 60 minutes. Sometimes we combine it with stress or rubidium PET. And the patient prep is absolutely critical here. So in this patient here on the left, we see diffuse uptake. And we talked about diffuse with the thyroid. We see the entire heart. What we're seeing there is glucose metabolism. That's not sarcoid. That patient was not prepped properly. But on this side, we see focal uptake. Okay, focal just means dots. This is sarcoid. All right, we're going to pair it with stress. Here's rubidium stress, rubidium rest. Here's the fasting. I see diffuse uptake. This patient was not prepped. That's non-diagnostic. Here's rubidium stress, rubidium rest. Now I see focal uptake. They also did a whole body scan, and the patient had sarcoid throughout their whole body. All right, so if there's no uptake at all, this is for sarcoid, that means they were normal and well suppressed. It's diagnostic and it's normal. Diffuse uptake, non-diagnostic, they failed to prep. Focal uptake, that's what you're looking for, active sarcoid. And the reason we pair it with the stress and rest is because we're looking to see if there's a focal defect where there's a perfusion defect. So this puts the patient at high risk because where there's a defect, now they also have inflammation. And maybe that inflammation caused the defect. All right, so this is just a comparison between amyloid and sarcoid. So again, amyloid is protein, sarcoid inflammation. Uptake pattern, we're looking for diffuse uptake with amyloid. We're looking for focal uptake with sarcoid. Prep importance, not important with amyloid. You can't mess this one up. Sarcoid is critically important. And the clinical impact, basically just know that it's going to affect cardiac function. All right, we got through cardiology in an hour. What questions do you have? Are you tired?
I'm okay.